Now we move on to the last talk of this session. This is a talk by Dr. Imran Majid. Dr. Imran Majid is the Associate Professor in Dermatology. He is Associate Editor in Dermatologic Therapy Journal. He is Director, Cutis Institute of Dermatology, Srinagar, and he is the past Chief Editor of Journal of Cutaneous and Aesthetic Surgery. Dr. Majid will be talking on targeted phototherapy in vitiligo.
Good afternoon, and thanks to the organizers for having me here today. So my talk would be on targeted phototherapy in vitiligo. We all know that the treatment of vitiligo has undergone a sea change over the last 1 or 2 decades. We have really come a long way from solar lens and sun exposure to really targeted therapies that target the presumed pathogenic mechanism in vitiligo. So we have targeted systemic treatments, now tackling the specific immune pathways in vitiligo, and we also have targeted surgical treatments like non-culture epidermal cell suspension technique and even melanocyte culture. Now, as far as lasers and lights are concerned, they are presumed perhaps among the most effective medical treatment options that we have in vitiligo at present. And they are used both for repigmentation as well as depigmentation, as Dr. Munish will talk later on that topic. And the biggest advantage that we have with these therapies is the rapidity of the therapeutic response that we get in repigmenting as well as in depigmenting. So it is with lasers and lights only that you can get a result like this over a few months, or a result like this over just 2 to 3 months by using a Q-switched ND-YAG laser. So what is targeted phototherapy in vitiligo? It basically means that we use a light source directly on the lesion without treating the uninvolved skin. And we use 3 different technologies here: the excimer laser, the excimer lamp, and the targeted UVB therapy. What are the advantages that these therapies have over whole body narrowband is that we have to treat the involved areas only, so there are no adverse effects on the uninvolved skin. The treatment here lasts for seconds, not for minutes. This shortens the duration of treatment. So you can use them even twice weekly or even once weekly. And you can use a super erythromerogenic dose also, as you have to treat only the affected area. So there is a maneuverable hand piece, so you can treat difficult to treat sites such as nose, genitalia, and there is a quick treatment response, probably the quickest with any treatment option, medical treatment option. And there is no adverse effect like hyperpigmentation of the unaffected skin. So targeted UVB therapy, we have basically 3 different types of devices in the world market. We have targeted broadband UVB, we have targeted narrowband UVB, and we have a combination of 2. This is the one that we have used for around 10 years now. So this is a Livia device which comes from US, and there are 2 different probes, one for psoriasis and one is specifically for vitiligo. This is a spectrum of this device. The light blue color that you can see there, this is the Livia output, and this basically has a peak around 11 nanometers. We published some studies on this device. We used it in adult vitiligo, and then we published a study on childhood vitiligo as well. And these are some of the results that we got with this device just after 12 doses and after 24 doses here. And we did get some results on the acral areas also. The protocol that we follow with targeted UVB is that we basically start with around 150 to 200 nanometers, millijoules per centimeter square, and then we increase the dose by 50 millijoules till we get a faint erythema, or if there is repigmentation that is seen there. So at the start of this faint erythema or repigmentation, we continue the same dose. Again, in the follow-up period, if there is a stagnation of the treatment response, we increase the dose by 50 millijoules per centimeter square. So in case of too intense erythema, we skip the dose and decrease the dose to the last tolerable dose. And in case of blisters, which ideally should not happen with targeted phototherapy, we skip the treatment for at least 1 week and then decrease the dose by at least 100 millijoules. So how do we assess the response to targeted phototherapy? In our center, we basically see the response after 10 to 12 doses. So if we see any evidence of repigmentation at 10th or 12th dose, then only we continue it. If there is no response at 10th or 12th dose, we either switch to some other treatment option or we add something in the form of any topical, systemic, or even procedural treatment. What about excimer light in vitiligo? We have used 2 devices till now, and these are the 2 devices that we have used. One is the Exiplex and the other is the Exis from GME, Germany. So the difference here is that excimer light uses 308 nanometers, and the protocol here is again the same, that we give twice weekly with a gap of 2 to 3 days between treatment sessions. And these machines have stencils with them that match the shape and the size of the vitiligo lesion that you are treating. So this prevents perilesional hyperpigmentation. For acral areas, we start with a heavier dose of 200 millijoules or even 250 millijoules per centimeter square. So here we start, as against targeted UVB, we start with a smaller dose of 100 millijoules or 150 millijoules. And on eyelids, we even start with a very low dose of 50 millijoules per centimeter square. And the increment in the dose is the same as with targeted UVB. So in case of stagnation of response, you again increase the dose by 50 millijoules till the patient tolerates, or you add some adjuvant treatment to the therapy. Combination treatments with excimer light have been used, and they have been shown to give us better results than monotherapy with excimer light. So we also use a lot of combination treatments. We usually use topical tacrolimus or topical FGF that was just discussed before this talk. So we use a lot of it in our patients in combination with excimer light or targeted UVB. And we certainly feel that it hastens the treatment response in our patients. And till now, we have not encountered any adverse effects with a combination of this fibroblast growth factor with the excimer light or targeted UVB. So in case we have a progressive disease, then we use oral treatments also, and they can also be safely combined with excimer light or targeted UVB. So we normally use oral antioxidants or oral methylprednisolone or betamethasone mini-pulse treatment. So combinations usually work better and give earlier results than monotherapy with excimer light. So here also with excimer, we assess the response after 10 doses or 15 doses in case of acral areas, and only patients showing some evidence of repigmentation at the 10th or 15th dose, we continue the phototherapy regimen. Otherwise, we give some alternative treatments or add some adjuvants. So normally in our experience, with a combination of topical tacrolimus or FGF with excimer, usually the repigmentation is seen around 5th or the 6th dose only. That means around 3 weeks after the start of treatment, you start getting some evidence of repigmentation in these cases. So this is one case that has received 10 doses of excimer light. So excimer light has proven efficacy in childhood as well as adult vitiligo. Excimer light has been shown to be as effective as excimer laser, so that's why excimer light is now preferred over excimer laser because of its cost and having the same efficacy. And repigmentation is seen within just a few doses of treatment, On an average, as I said, 5 to 6 doses of treatment and you start getting repigmentation. You see both perifollicular as well as marginal pigmentation in these cases. Head and neck areas are the best to respond. Acral areas respond late. But I think of all medical treatments that we have, excimer is probably the best repigmenting strategy that we have for acral lesions. Perianal areas, eyelids, and other sensitive areas can be treated safely with this treatment. Adverse effects are rarely significant enough to warrant discontinuation of treatment. Erythema, burning sensation is the commonest that we get in these cases. Blistering can occur, but as I said, it should be a very rare phenomenon if you really use the treatment well. Hyperpigmentation of perilesional skin is sometimes seen, and this is because the shape of vitiligo lesion is sometimes not the same as the shape of your stencil that is provided with the machine. So this is one of the cases with methylprednisolone oral mini pulse. So you can use either betamethasone or methylprednisolone in your mini pulse. So this is after 20 doses. So you can see that the progression has stopped and there is a nice repigmentation after 20 doses. With topical FGF, as I was talking earlier, you can use it safely and with good results in combination with excimer light. This response needed 30 doses, again with topical FGF. And this is with topical tacrolimus, so you get a very good response in face and neck. What about excimer light in segmental vitiligo? How effective it is? So we published a study last year on this. And what we found is that early treatment of segmental vitiligo gives excellent results with excimer light. If we start treatment within the first 6 months of onset of segmental vitiligo, you can get results in almost 100% of these cases. And of all types of vitiligo, I think segmental vitiligo should be the one that should be really treated first of all with excimer light, going with the results that we have seen in this specific type of vitiligo, which is traditionally considered unresponsive to medical treatments. And if you start treating these patients within 6 months, you can prevent the occurrence of leukotriecases also. So this is a case of segmental vitiligo with leukotriecases on the chin. So you can see a nice response and some reversal of the leukotriecases as well. A young child with segmental vitiligo, this around 20 to 25 doses of excimer light within the first 6 months of onset of disease, and you get excellent results in these cases. Again, a child with segmental vitiligo on the left side of the chin. Now, can we have similar results with once weekly targeted phototherapy if we compare it with twice a week targeted phototherapy? So we did one study on that and we found that if we use once a week excimer or targeted UVB, the results are almost the same as with twice a week treatment. Only the thing is that the patient will have just 4 doses in a month instead of 8 doses. So it will take longer time to see the response. But the number of doses that are needed to get the repigmentation and the cumulative dose is the same if we use once weekly or twice weekly treatment options. So this was some photographs from that study of comparison between twice a week and once a week. And we basically compared site-specific response, because we know that some sites respond better than the other site. So face was compared with face, limbs were compared with limbs. Now, last query is, among excimer light and targeted UVB, which one is better? Because we have used both, we have used targeted UVB, we have used excimer. So we did one retrospective analytical study, and this was published last year. we looked at which one is better. Is targeted UVB better or excimer better? So we found that both of these devices give really good results, but excimer light probably scores or targeted UVB with a relatively better repigmentation response than targeted UVB. Adverse effects are the same with the two devices, but you need a lesser cumulative dose of with excimer as compared with targeted UVB to get the same therapeutic response. And you can use excimer with grafting procedures as well. So once we use a surgical procedure, if we don't get a good response after 1 or 2 weeks or 1 month, you can start using targeted UVB. And it can be started just 1 to 2 weeks after the dressing is removed. So you can get a very rapid onset of repigmentation. And the total time taken for repigmentation is also reduced. And another indication where we use it is for treatment of perigraft halo. And it does help in a good percentage of patients. The only issue would be that in some cases, you can get a hyperpigmentation, which should not really happen. So this is one case where we use targeted phototherapy for treatment of perigraft halo. And this is how the results can be improved. Thank you so much.
Thank you, Dr. Majid. That was quite an exhaustive insight into something which intrigues all the people who treat vitiligo. And I would like to invite a couple of questions if they are there. Dr. Manish, please.
Just wait.
Quick question. Do you give target or excimer over the genitalia?
Yes.
Why do we conventionally say genitalia should be covered when we give phototherapy? And I hear this, a lot of colleagues actually prescribe excimer over the genitalia but not full body phototherapy. What's the logic?
I think that protocol basically was with PUVA rather than narrowband. But yes, it was extrapolated to narrowband then, because we saw malignancies in the genital areas with the use of PUVA, but then that was extrapolated to the use of narrowband UVB. But I think you can really safely use excimer in genital areas, and by genital areas I mean the vulval area or the scrotum. You can use it safely.
Not the
we have used it and we have found no issues with these.
Not the penile shaft?
The penile shaft, personally not used in any of these cases, but I think can be used. It should not be an issue.
We can use it on the eyelid skin, which is as thin as anywhere on the body.
You can use it on the eyelids. So
why not the other way?
True.
Thank you, sir.
Yes, ma'am.
Ma'am, if we have a lesion on the eye, so we don't have to use an eye. We don't have to use an eye shield. No.
For the eyelid, you are not using eye shield?
Inside the eyes?
Yeah.
No. We don't use it. No.
Okay.
No. That we use once we are using a Q switch and or some lasers, but no, not with excimer. We don't use it. But yes, on eyelids, the dose has to be given less. That's true.
1/4. So thank you, Doctor.
Thank you.
I think we have one last question here.
So one last question. If we get a patient who has got 4 to 5 lesions, but they are smaller lesions, is there any limitation to the patches that we give with an excimer laser, or do we should just shift them to a narrow band? So I just wanted to know, what is the area? Is there any body surface area that you see, or if we can even give 5 or 6 patches on a single setting?
You can easily. You can use if the area involved is not too much. You have less than 5% body surface area, 10% body surface area involved. So you can safely use it. Yes.
Till 20 to 25 exposures we can give. So is there any limit that because if we increase the number of patches, then obviously the surface involved would be more in each sitting?
Sure. See, you have to make a choice. If you have both treatments available, you have narrowband, you have targeted. You have to make a choice depending upon the patient. look at him or her and see what can really suit him better. I think that is how we can answer that question. Thank you.
Thank you, Dr. Majid, and that brings us to the end of this session. And